Hello everyone and welcome to our module on newborn hyperbilirubinemia. Let's start with a brief review of the metabolism of bilirubin in the human body. Bilirubin derives from heme. When heme from red cells and other sources is broken down, it becomes unconjugated bilirubin, also known as indirect bilirubin. This form of bilirubin is not soluble in water and therefore it's carried by albumin to the liver. And in the liver, molecules are added to bilirubin to form another type of bilirubin called conjugated or direct bilirubin. This form of bilirubin is soluble in water and it can be excreted in the bile, and that's the way that bilirubin is eliminated from the body. In terms of newborn babies, most newborns develop some degree of unconjugated or indirect hyperbilirubinemia. They have abnormally high levels of unconjugated bilirubin in the plasma. There are a couple of reasons why this almost always happens in newborn babies. The first is that fetal red cells have a short lifespan, so they turn over more quickly, and that generates more unconjugated bilirubin. In addition, the newborn liver is immature and it has a decreased rate of metabolism, so it's not able to conjugate and eliminate bilirubin as quickly as the adult liver. And then lastly, there are intestinal flora which assist in breaking down bilirubin so it gets excreted from the body. But newborn babies have a sterile gut, so they have less bacteria in their gut, and therefore they don't eliminate bilirubin from the body as quickly. So for all of these reasons, most newborn babies develop some degree of unconjugated hyperbilirubinemia. This is often called physiologic hyperbilirubinemia in a neonate because it's just a normal response to the status of the body in the newborn baby. Usually this is not dangerous. The levels will peak at about 2 to 4 days after birth and then begin to decline by about a week. And the normal adult total bilirubin is less than 1, and the normal peak in an infant is usually about 8 or so, which although this is elevated, it's not elevated to the degree that usually causes neurologic damage, as we'll talk about later. So as I said, most newborn babies have some degree of unconjugated or indirect hyperbilirubinemia, and this commonly causes the baby to become jaundiced, which means they develop a yellow discoloration of the skin, like shown in this baby on the screen here. Jaundice usually develops anytime the bilirubin level climbs above about 2 to 3. And an important distinction in babies with jaundice is whether or not the jaundice occurs below the umbilicus, meaning on the skin of the lower body, and whether or not the jaundice causes icterus, which is yellowing of the eyes. If there is jaundice below the umbilicus, or if the eyes are icteric, that usually means the bilirubin is very high, and that's a sign of a more severe elevation of bilirubin levels. There are a couple of ways that bilirubin can be measured in a newborn baby. One of the most common ways is to use a simple device called a bilirubinometer that shines light on the skin and uses the light reflection to estimate the level of bilirubin. You can also do a formal blood test and measure the level of total bilirubin, indirect bilirubin, and direct bilirubin. And what you're worried about in babies in terms of bilirubin is neurologic damage. This can happen when the level gets above 25. For most babies, the level won't get anywhere near this, but this is why you always monitor the bilirubin level to make sure it doesn't climb this high. In newborn babies, there's a graph called a Butani nomogram named for the person who created the graph, and it's used to identify infants that are at risk of severe hyperbilirubinemia. The graph has the postnatal age of the baby in hours along the bottom, so depending on how many hours the baby is old, you find where they are along the x-axis. And then on the y-axis, you plot their serum bilirubin level. And based on that, you can decide whether or not the baby is in the low-risk zone down here, the low-intermediate risk zone, or the high-risk zone. Babies that are in the low-risk zone are very safe and are very unlikely to go on to develop severe elevations of bilirubin. Babies that are in the high-risk zone or up in this range are at much higher risk, and those babies are monitored more closely and sometimes treated for the high bilirubin level. So the reason bilirubin is dangerous if it gets too high is because it can cause bind, which is bilirubin-induced neurologic dysfunction. The reason this happens in babies is because unconjugated bilirubin is soluble in fats, and therefore it easily crosses the blood-brain barrier. And remember, newborn babies typically develop an unconjugated hyperbilirubinemia for all the reasons we talked about before. Once bilirubin gets into the brain, it acts as a neurotoxin, and it can damage the basal ganglia and the brainstem nuclei, and this can lead to permanent neurologic damage. Like I said before, this usually doesn't happen until the bilirubin level gets very high, usually above 25. If the bilirubin gets this high, it will cause bind, and the initial features will be lethargy and hypertonia in the baby. If it's left untreated, the baby can develop a coma and seizures, and it can lead to the development of 2 motor spasm problems, which we'll talk about on the next slide. So opisthotonus and retrocalis are forms of muscle spasm that can happen to babies who have bind. This is really historical. We don't see this in the modern era, but decades ago, when there was no treatment for hyperbilirubinemia in newborns, babies would get very jaundiced and then develop these forms of muscle spasms. The first one is called opisthotonus. This is spasm of the back. It looks like what's shown in this image on the screen. The head and legs bend backwards and the trunk arches forward. And then retrocalis is a backward arching of the neck. So decades ago, babies would develop these features if they had severe neurologic damage from high bilirubin levels. So bind is an acute response in the baby to high bilirubin levels. Kernicterus, on the other hand, is a form of chronic bilirubin encephalopathy. It's permanent neurologic damage that results from babies being exposed to high bilirubin levels. And the clinical features of this can include movement problems like cerebral palsy. There can be hearing loss and gaze abnormalities. The teeth can underdevelop. This is called dental hypoplasia. So once again, this is largely historical, but decades ago, when there was no treatment for hyperbilirubinemia, babies would develop bind and then go on to have kernicterus problems for the rest of their lives. The reason that babies in the modern era don't develop kernicterus is because we treat them when they develop significant indirect hyperbilirubinemia. And the treatment that is usually used is called phototherapy. This involves placing the baby under a special light as shown in the picture on the screen here. And what this does is it exposes the baby's skin to light of a specific wavelength. And this wavelength of light converts bilirubin into a related substance called lumirubin. This is an isomerization reaction. Lumirubin has the same chemical formula as bilirubin, but a different chemical structure. And because of that different structure, lumirubin is more water soluble, and this allows it to be excreted without having to go to the liver and become conjugated. And therefore this increases the excretion of bilirubin and brings the level down until the baby develops enough to be able to process the bilirubin on its own. Most babies who develop an indirect hyperbilirubinemia have physiologic hyperbilirubinemia. This happens because the liver is immature and the gut is sterile and all those things we talked about a few slides ago. But some babies develop more severe or prolonged hyperbilirubinemia for one of these reasons shown in this slide, and so we'll go through each of these in the remainder of this video. Breast milk jaundice is the persistence of benign physiologic neonatal hyperbilirubinemia beyond the first few days or the first week of life. It occurs in babies that are breastfed, and it happens because babies consume an enzyme in mother's milk called beta-glucuronidase. This enzyme increases the GI absorption of unconjugated bilirubin and causes the baby to have a higher level of unconjugated bilirubin in the plasma, and I'll explain more about this in just a second. These babies develop jaundice that appears about day 3 or 4, sort of around the time of usual physiologic jaundice, but then it persists and doesn't peak until about 2 weeks of age, and it declines to normal levels by 12 weeks of age. Other than being jaundiced, these babies will appear entirely healthy and they will be feeding normally. Remember, it's the milk that they are feeding on which is causing the jaundice. And usually this is a mild form of hyperbilirubinemia and it usually doesn't require any treatment. So as I told you before, heme breaks down into unconjugated bilirubin, which goes to the liver to become conjugated bilirubin, and that then goes out into the intestines in the form of bile, where some of it will be excreted. But there's an enzyme in the brush border of your intestines called beta-glucuronidase, and this converts some of the conjugated bilirubin in the intestines back into unconjugated bilirubin, which is absorbed. So in babies who develop breast milk jaundice, they are consuming beta-glucuronidase in mother's milk, which makes this process happen at an increased rate, and therefore more unconjugated bilirubin is reabsorbed as part of the enterohepatic circulation of bilirubin, and that's why breast milk jaundice occurs in some babies who are breastfeeding. Another reason that babies can develop more severe or prolonged hyperbilirubinemia is because of something known as breastfeeding jaundice, which is totally different from breast milk jaundice. Breastfeeding jaundice occurs when the baby is having trouble feeding from the breast and is getting inadequate nutrition from lactation. These babies aren't taking in enough fluid and calories, and as a result, there's more enterohepatic circulation of bilirubin. These babies aren't producing much stool, so the bilirubin is not going out in the stool, and more of it is being reabsorbed than usual. This causes jaundice that appears in the first week of life and will persist beyond the usual first few days of physiologic jaundice. Importantly, the baby will have signs of hypovolemia and weight loss and poor weight gain, and usually the mother will report that the baby is having trouble attaching to the nipple and breastfeeding. There can also be signs of volume depletion on exam, things like dry mucous membranes and poor skin turgor. And the treatment for this form of jaundice or hyperbilirubinemia is to help the baby latch onto the nipple and be able to take in more nutrition through lactation. Hemolysis is a very rare but life-threatening cause of unconjugated hyperbilirubinemia. This often causes jaundice in the first 24 hours of life, and this is much quicker than the other forms of jaundice like physiologic and breast milk jaundice. The feared cause of hemolysis in a newborn baby is erythroblastosis fetalis. This is what happens if a mother is Rh negative and has antibodies to the Rh antigen on red cells, and then her baby is Rh positive. Some of those maternal IgG antibodies can cross the placenta, and the baby can develop hemolysis in the first 24 hours of life. This is rarely ever seen in the modern era, and that's because we blood type the mother and we administer treatment if she is Rh negative and may have an Rh positive baby. So most babies develop physiologic indirect hyperbilirubinemia. A small subset will develop either breast milk or breastfeeding jaundice. Beyond that, hemolysis and all the things listed on this slide are very rare causes of indirect hyperbilirubinemia in a newborn. It's very unlikely you'll see them clinically. Crigler-Najjar is a condition I talk about in the gastroenterology section. Patients with this condition are born lacking an enzyme in the liver that is necessary for conjugating bilirubin, so they develop a severe indirect hyperbilirubinemia at birth. Congenital hypothyroidism can cause indirect hyperbilirubinemia, so can galactosemia. Galactosemia is an inborn error of metabolism where babies can't process galactose found in milk. Spherocytosis is a red blood cell disorder where there's hemolysis of red cells, and that can lead to a significant indirect hyperbilirubinemia. And then lastly, babies who become septic often begin hemolyzing their blood, and they can develop an indirect hyperbilirubinemia as well. I'll finish with one slide on direct hyperbilirubinemia, otherwise known as conjugated hyperbilirubinemia. If you see this in a newborn baby, this is always pathologic. This is not going to be a physiologic process. If a baby has high direct bilirubin levels in the plasma, this means their liver is conjugating the bilirubin but is unable to excrete it into the intestines through the biliary tree. This means there must be a problem either with getting bile out through the biliary tree, some form of biliary obstruction like biliary atresia, or some problem in the liver where the liver can't get bile into the biliary tree. But it's very high yield to know this for your boards. This is a classic trick question. If they show you a newborn baby with a direct hyperbilirubinemia, the answer is not going to be any of the things we've talked about in this video, like breast milk jaundice or physiologic jaundice. There must be some problem with the biliary tree or the liver. And that concludes our module on newborn hyperbilirubinemia.